Hello and welcome to this episode of the OncoPT podcast. We are continuing our CSM preview sessions with an amazing session with something that I'm not very comfortable with. And I think a lot of us, especially newer OncoPTs, tend to struggle with. And that is pediatric oncology and what the heck we can actually do with these tiny patients who come to see us. So I've brought in some experts who are going to tell us exactly what we need to know, plus where we can get more information at their amazing upcoming CSM session. So first, I'm going to introduce the first of our two speakers, Dr. Nashwa Khalil. Would you mind introducing yourself, please?
Sure. Hi, everyone. My name is Nashwa. I'm a physical therapist at NYU Langone Health. I've been there since 2014, and I work with the pediatric population now. But I started as a rotator position in adults, and in 2015, I think is when I first got my feet wet in pediatric oncology, and that's when I was like, oh, I need to learn so much more. And so in 2016, I went to CSM, and that's where I met yours truly, Lynn Tanner. And she her drive and her passion to improve rehabilitation across the continuum of care for kids with cancer just blew my mind away. And, she mentioned the Children's Minnesota Mentorship Program, which I applied for and luckily got into, which was amazing. And it's just been a game changer ever since. And so, we've stayed connected ever since, and here we are.
I feel like that's the dream, is like you meet a hero and then you get to work with them, and it's just like amazing. Now to introduce that hero, we have Dr. Lynn Tanner back on the OncoPT podcast. Lynn, welcome. I'm so excited you're here.
Thank you. I'm excited to be here again. It's fun to talk about pediatric cancer rehab, right? Any chance?
Yes.
Any chance we get.
Yep.
Lynn,
perfect. No, I was going to say, I know you've been here before, but there are new listeners, so can you tell us a little bit about you, please?
Yes. My name is Lynn Tanner. I am a physical therapist I'm at Children's Minnesota. I just transitioned into a full research role, but that is after 20 years as a physical therapist. And then I created my own position called the Rehab Clinical Specialist at Children's Minnesota. So I did that for 13 years, which was a combination of clinical work, program development, which is what we're going to be talking about at CSM, and then research. So I was kind of able to combine everything I loved all in one job. And now I'm transitioning to research alone because we have a great team of therapists that are doing all the work. So that's
incredible. That is so cool. Nashwa, I'm actually going to turn this back to you. And I were speaking off air before we started recording about how you met Lynn, because my question was, Lynn's in Minnesota, you're in New York. How did these two brains collide to start this whole endeavor?
Yes. So as I mentioned, in 2015, when I started getting my feet wet in the pediatric oncology rehabilitation world, which is not a world I knew anything really about until I got introduced to it at work. I wanted to learn more. So I forget the title of your talk back in 2016, Lynn. It was probably something about PT rehabilitation implications for children with cancer or something like that. Does that sound about right? Well, I went to her talk and I was like, oh my gosh, there's so much to learn. And there's so much to bring back to my institution so we can help with the program development piece of it. And that's when she introduced their program, which was, it's called the Children's Minnesota Oncology Rehabilitation Mentorship Program, which is almost a week-long program where you get one-on-one training and all this didactic information all about evidence-based care for these kids. And so that's when we really got to connect, and we've pretty much stayed in touch ever since. They do a really good job with, keeping in touch with the therapists that they've mentored. And Lynn and I also have thankfully become friends. So we're
Yes,
able to collaborate.
it's a plus. I know. Well, it's amazing. When I got into this field, I couldn't find virtually anyone doing pediatric oncology rehab except for one. Tori Marchese had published a couple articles. So I reached out to her and she was wonderful and talked to me way back when. But I wanted it to be different, right? And so it's so rewarding. Honestly, this conversation is rewarding to me because you work so hard and these kids benefit from physical therapy and occupational therapy and speech language pathology in so many ways. And yet we're not reaching them. And then you find other people and you can see it. And Nashwa, you could see it. Like she came to Minnesota, not in the middle of winter. And
It was still pretty cold.
Yeah.
It was like November or something.
I mean, you
For
could come
you,
now.
for you.
Yeah, right. And I mean, you can just it's easy to feel somebody who's excited and driven and asking questions and sharing their perspectives on it, and you learn from each other. And I think you need people like that to keep going and to keep making things better for these kids, right? So I think it's so fun that there's so many more therapists now interested in the field, and that only brings more services to more kids and more research, and we can just learn faster. So.
Absolutely.
Agreed. So Nashwa, back to you. How in the world did you decide that you wanted to do a CSM session? Like, how did this whole effort come together? Because, I mean, obviously, like, the two of you and then the rest of your team are kind of like the dream team when it comes to pediatric oncology stuff. So, like, walk me back through, how did that process start for you?
Yeah, I think that the process started long ago, right? When we decided to really implement a prospective surveillance model at our institution, take all the tools and everything I've learned from the mentorship program and really try to implement it as a staff physical therapist. And I think Lynn and I have always kind of agreed that every institution has its challenges, and and some are similar, and some many other therapists will completely get and be like, yeah, I know exactly what you're talking about when it comes to certain systemic challenges. And so, we've always kind of discussed this type of stuff because the work never really ends. Like even to this day, there's always something to do to improve your program and to improve your reach. And so we're always talking about that. And we feel like there's so many other therapists out there who are also probably struggling to build their own programs at their own institution. And so we just thought, why not bring up, our experiences at two different institutions and, the barriers that we both face, some that are specific to our respective institutions and some that are shared, and see how we handled it and what we're continuing to work on, going forward, because it never ends.
That is one of the main lessons. The development never ends. There's constantly things changing in a program, and you have to change with it. And you don't want to be alone doing it, right? So the more we can talk to others and learn from others' experiences, and things can move faster rather than you at your institution kind of just having to solve the problems what feels like on your own, right? And why wouldn't we bring all of our experiences and all of our ideas and the research all together to make it better for everyone and faster for everyone and more efficient, right? I mean, everything from the electronic health record and what can you do through that process, and what can you do to make sure that you're connected to your oncology team, and what can you do to make sure you're getting administration support. we have these little tips and tricks that have helped us personally. Will your experience be different? Maybe, but it at least gets you started, right?
Yeah. Mm-hmm. So I think we need to address the elephant in the room, and then we'll kind of work our way backwards. Can physical therapy actually help a child going through cancer and cancer treatment? And the reason I ask this is I'm sure there's a listener out there who's saying, Elise, of course we know that this is. Like, you have 2 pediatric oncology therapists on the call with you. But for the first time in my career, I was working with somebody that I was teaching. And this person, who is actually a childhood cancer survivor themselves, was so resistant and was so adamant that rehab was not beneficial for these kids. And it blew my mind. So let's get this out of the way. Can physical therapists actually work with kids who have cancer and are undergoing cancer treatment?
Yeah, I mean, absolutely. You are talking to 2 therapists who specialize in this field. You know, today's current model is a lot more than just, curing cancer. Now there's so much more attention to detail to the psychosocial development of a child, their physical well-being, right?
Mm-hmm.
And so PT plays such an integral role in that. We know cancer and cancer treatment is happening at such a pivotal time during their development, really.
Mm-hmm.
Their sensory systems are still developing. They're still learning to integrate. And then you're throwing on top of that cancer and cancer treatment, which has, a wide variety of side effects and toxicities that can really impact their ability to interact with the world, their ability to participate and play, their ability to be children, really. And so when I think about our role, I just think of our role as being, helping our kids get to being able to do everything any other kid who isn't going through cancer treatment do. So like a 5-year-old running or skipping or running or participating in in play, which is what their occupation is, right?
Yep.
And so, yeah, I mean, we see it every day. Our kids are not just thankfully surviving cancer, but now they're like thriving. They're being able to be kids and participate in age appropriate skills, which is the ultimate goal.
Yeah, I agree fully, and we now have research that backs it up, right? So I mean, while they're small studies, there's a number of exercise trials. There's the research on the stoplight program that shows that not only we can help these kids reach their developmental milestones and or regain skills or prevent the loss of skills, which the prevention word is wonderful. And it lasts. There's a sustained benefit. So we have data that's 2 years after treatment. Now I'm looking at data that's greater than 5 years after treatment of kids who's had PT compared to historical controls. And yes, it makes a difference. And it not only makes a difference during treatment, which just that alone, it changes their trajectory for that child, right? So if I'm 8, these stories come up, if you have an 8-year-old and they're in school and you say, oh, what do you do during recess? And they say, oh, I love to sit on the bench and talk to my friends, we'll share stories. And you're like, oh, do they play tag and Foursquare? That's an old game. It's Gaga Ball now. What do they play? And they'll be like, yeah, if I play tag, I'm always it. So why would I play it?
Yeah.
Right? So right there, that experience that an 8-year-old is having for even if it lasts 4 months in their cancer treatment changes what they think about how they socialize with their peers, what they think about physical activity, what they right there you're like, oh, you're giving them an attitude about physical activity possibly for the rest of their life. And that is scary. And when we know when we know the evidence on what physical activity does to prevent, some morbidities in survivorship, that's pretty huge. So, I just, yes, kids are amazing and resilient and funny. And I just think there's so much that we can do, and we shouldn't sell them short. When I first started seeing kids, the families, we met some kids in research, and they, I watched them, and they had like a grade 1 out of 5 dorsiflexor, right? And I'm watching them walking down the hall, thinking, and the family is saying to me, "Oh, everything's great. We couldn't be happier. They're done with cancer treatment, going to school." And I'm sitting there going, "But they have a grade 1 dorsiflexor." Like, what? But it was just because that was what their bar was set at. That, hey, she survived cancer. And now it's like, oh no, you're not only going to survive, you're going to thrive. So the answer is yes. And I think we're just learning what we actually can do and what our role is in cancer treatment, and and as they change cancer treatment, what our role is as physical therapists. I think we're just starting to learn that.
And one thing that I heard you both say is this concept of not just surviving cancer anymore, but thriving. And it's really interesting that we're now really getting to the point where we're really starting to ask ourselves, I think as an oncology community, not just as physical therapists, but as the greater cancer care world that we're in, these patients are surviving their cancer for longer periods of time across the board, but at what cost to them physically, mentally, cognitively, emotionally, psychologically? And I think we have such a perfect opportunity and a role to step into to really address those again, to not just make it a survival issue, but a thriving, a living after cancer and cancer treatment.
Absolutely.
And I think a lot of that falls to, what are our expectations? What can we do? And I think, in watching things progress over the years, sometimes you rise to your expectations, right? And if our expectations was, which is very important to survive cancer, yes, but man, these kids have a long life to live.
Yeah.
And their bodies can recover so well, I think, with a lot of hard work, though, So I think I just always, think about, what if I was a parent? What would I want for my child? And you listen to the parents and what they, I had a parent say to me long ago, and I'll never forget it. I want my child, if they want to go to the Olympics, I want them to go to the Olympics. And I said, okay, we'll do that. And, and I've always said to actually my own kids, like, if one of my patients ever goes to the Olympics, we are all getting on the plane. Because I think it's possible. And I think but it's going to take the work of, like you said, the community from everywhere, from the physicians, nurse practitioners, nurses, therapists, child life specialists, psychologists, all of us, to support, to give the support that we would want for our own families.
I think a lot of listeners are really familiar with the prospective surveillance model approach. I actually interviewed Nicole Stout, who is like, a name is synonymous with prospective surveillance model, last year. And one of the things we talked about was, it was this landmark study that came out actually 10 years ago last year. And we kind of talked through some of the challenges and whatnot. But what I think is so interesting is that oftentimes, or at least I'm most familiar with, prospective surveillance model being implemented in like breast cancer patient populations. And I'm not that into the peds literature. I will let you know that right off the bat. But I don't feel like prospective surveillance model in peds aren't necessarily like, I don't feel like I've heard of that much so far. Can we talk a little bit about that?
Yeah, I think that you're right. It started really with the adult population. That's what kind of made that such a buzzword. But it's just as applicable and important in the pediatric population.
Totally.
Facilitating early detection and treatment is so integral to prevent, to mitigate impairments that we know are so common in certain populations and with the treatments that they're getting. Um, and so, it just, even when I first started at NYU, um, we had little bits of pieces of the prospective surveillance model. But really, we were more of a symptom-based type of model. And,
Right.
it took, a kid to get half foot drop, a year into their treatment for leukemia for PT consultation to happen. Whereas now we know over 80% of our children with who are getting, vincristine do get some form of neuropathy. So
Yep.
why not get a baseline assessment and surveil these children throughout their treatment and make sure that that whatever impairments that we can catch early on are mitigated and that we address them early on so that they can, fully participate in age appropriate skills. So I think like a big piece of that, and we will talk about this in our actual CSM talk, is being clinic integrated. And that's also something that, you see in the breast cancer population as well, where a clinic integrated therapist, whether it's PT, OT, speech, is so integral in also making that a reality for our kids, because it's just so much easier, so much harder if you're not on the ground at the oncology clinic, because then you're so disconnected, and then you're waiting for a referral that probably won't happen early enough.
Yep.
Yeah, I couldn't agree more. I think, we started seeing kids with acute lymphoblastic leukemia from diagnosis starting in 2005. And then I integrated in clinic in 2009. And both of those things had significant changes in our access numbers.
Yeah.
So I think, and we'll talk about that in our session of what, it's not just one thing. So you can say, and I think that's what Nicole has been so wonderful about continuing to advocate for the prospective surveillance model, because while it was found 10 years ago, it's still not being done. And so what are the barriers and how do we overcome them? Because I don't know. I mean, you can read article after article after article that says rehab is needed. Rehab is needed. Yes, we recommend rehab for patients with cancer. I mean, we've all read those, right?
Right.
More rehab is needed now, which is wonderful because 15 years ago it wasn't there.
Right.
But,
right. Absolutely.
Right?
Absolutely.
So we are making strides. But I think that's what we really wanted to get at this session is, okay, we know we need to do this. So now what are the nuts and bolts of how we actually get this done in two different places? And that's why we'll also have, we'll have an administrator and an oncology director also involved in the talk, so they can talk about it from their sides, because they were integral in getting both our programs started. And so how do we, I think that's what we want to do in this session.
Yeah. Going back to something you said earlier, Lynn, was about implementing this approach, not just like, hey, we need to make it happen, like, come on. And that coming from a rehab side of things, but also, especially when it comes to implementing a cancer rehab program, there has to be buy-in at every level, in order for it to really, I think, take hold and actually become a sustainable and effective program. What are some of the barriers that are out there when it comes to implementing the prospective surveillance model in the pediatric oncology world?
There was actually a survey study published on this. It talked that interview patients from, or I'm sorry, therapists from, I can't remember how many, over 100 hospitals. And people, education, so education for therapists, so to have trained therapists that are available to see these patients, resources, right? I mean, places have to have resources and all different types of resources, from staffing to equipment to space. Buy-in from oncology is certainly a barrier, but I think we'll talk about ways to overcome that. I think we're so much closer to that now than we used to be. What am I missing, Nashwa?
Space, resources. You need the grounds on the. You need what is that phrase? But you need
boots on the ground.
Boots on the ground. Yeah.
Boots on the ground.
You need the boots on the ground.
Relationships too.
You need the You need somebody who's going to be persistent, even despite all the barriers that they're going to face, because it's not always an easy ride, and there's going to be barriers no matter what institution you're in. And I think a big piece of it is just being persistent, and having champions across different, like you can have PT champions, you have administrative champions, you have nursing champions, people that have that buy-in you were talking about, to help make this all happen, because it's a huge collaborative effort, and it's really not possible without all the bits and pieces coming together and working in a systematic, functional way.
Right.
I think it's too. I think we have to give our colleagues the benefit of the doubt that it's not even that they don't buy in. It's that how do they fit it into their priorities of everything that they need to take care of. Right. And so it's not. I think that there's a lot of providers that see the benefit of rehab, but they also have to prioritize what they're facing in the day, right? And what they need to take care of. So how can we work within our institutions and find people that can be champions, and that they have they have that interest and a little bit of bandwidth to give to it, And I think part of that is relationships and conversations over and over. But
yes.
We're people. We're human beings. We need relationships, not just messages across EMR. Because maybe some therapists might be doing that. I'll just send a quick message. I'll just send it, but they don't know your face yet, so that message doesn't really mean anything. Yeah. And when somebody knows your face, somebody knows they have that connection with you. You talked about a patient with them. You connected like human beings connect. Well, now when you send me a message through EMR, I go, oh, okay. Yeah. Hey, we need to, right? Those relationships still are really important. And I think we need to really pay attention to that now, especially post-pandemic, right? I mean, I love technology and I love remote work and I love, I love telerehab. There's so much we can do, but I also think we have to remember that we're human beings at our core and that we connect, and building a program.
Absolutely.
That's a core component. So.
Yeah. I really appreciated, again, this is not a Nicole Stout fan podcast, but it may as well be. When I interviewed Nicole, she really framed it in a way that I had never considered, because I tend to be one of those like black and white rule follower. Like, you give me a framework and I'm going to put it into practice exactly how I've been told or shown to do it. And she really talked about the prospective surveillance model is a framework to implement, but then to customize it to the individual challenges and the environment in which we work within our separate institutions. I'm in Texas, Lynn is in Minnesota, Nashwa is in New York. Like, there are, like, I know you're already picturing differences between each of our respective states at this point. And so I really resonate with the concept that y'all are talking about as far as making those human connections and identifying those key relationships with the individuals who are potentially in positions of decision-making power that could really help you make this effort happen. So without giving everything away, Nashwa, because we obviously want people to come to your CSM session, what were some of the relationships that you identified that you said to yourself, this is someone who needs to be on our team, who needs to, like this, they need to be on the pediatric oncology rehab train. Let's get to work on that.
Yeah, I think it's so important to have those relationships like Lynn was saying. And I think early on, I learned having rehabilitation administrative support, as well as medical leadership support. They're both so important, because we'll talk about the details of like our barriers at our respective institutions and whatnot, but justifying having a therapist in a clinic, there's so many decisions that have to be made to make that happen. There's space, there's resources, that need to be discussed. Like when we first started, we didn't even actually have a space. So we were working in like the hallways, basically. So, I wasn't going to create a gym. So I needed medical buy-in, administrative leadership buy-in to realize how important it is for PT to not just be an extra part of these kids' care, but to be the standard of care for our kids. And having an actual space is just one piece of the picture that kind of makes it more real. And there's so many examples of that just can't happen without the support of leadership and administrative positions, both in the rehab world and in the medical oncology department. I don't know. Am I missing anyone?
I mean, I think a nursing leader is also really helpful. Growing a program, they know the patient's journey very well, and I think that leader is important as well. The other leader that we also use to do is foundation. The foundation, of your institution. If you're looking at resources, you should know somebody in the foundation, because they might know of donors, they might know of grants, they might know. So having that connection and champion also for your program is also beneficial.
One of the challenges I think that many patients, many families, but also many rehab professionals face is like, if you're in a academic institution or large major hospital system, there's connections that are kind of inherently built in. Now, are they always maximized? Not necessarily, but for someone like me who is actually a private practice owner, or maybe works at a smaller clinical setting that doesn't have these connections that are just built into this large institution, but knows that this is a need in their community, are they going to get benefit from the CSM session?
I think so. I mean, I think the thing is, if it's something they're interested in, a lot of the concepts are going to be helpful, because, for example, if they want to go to pediatric oncology continuing education, they're going to need some support. And what can they bring back? So that they can get supported to go to a continuing ed conference. Or I mean, I definitely there's a lot of disparities in cancer care, and so we can't do it all at large institutions. We need private practice, we need rural institutions, we need right. And so that is a service that is needed. So I think while some of the concepts I think it'll bring ideas to the forefront. Even though we come from large institutions, we work with I've had many, many conversations and with people in private practice or that lived, 4 hours away in a small town. And I can tell you what I would learn their name and you could tell they're very interested in this. Wow. Oh, okay. And so then when I had a family that lived near there, do you know any physical therapists? I would say, oh, right, I do.
Mm-hmm.
So
Mm-hmm.
I do think that a lot of the concepts that we will be talking about will be helpful.
Very cool. When is your CSM session so people know to sign up and make sure they get butts in seats for this session?
Our session is on Thursday, February 23rd at 11 a.m. Hope to see you guys there.
And would you mind telling us, Nashwa, the full name of your CSM session, please?
Sure, absolutely. The name is the Trifecta for Success, building a pediatric oncology rehabilitation program from the ground up.
Can I ask who came up with the title? Because it is brilliant.
You like it?
Yes!
I think it was both me, Lynn, and I.
I think we talked about it together and we kind of came up with it collaboratively.
Yeah, I forget what came, how the trifecta, like I like the trifecta word. I don't know if that sounds like a Lynn word, but it was a long time in the making. So
I feel like it just really spells out, like, I know I feel inspired by the title, so I have to go to this session because I know I'm going to learn stuff.
Oh, amazing.
Nashwa, Lynn, holy cow, like, this session is so exciting. It's so needed. And unfortunately, one of the things we talked about off air before we began this interview is just how underserved this patient population is. We know cancer rehab is underserved, but pediatric oncology especially. So it's time for us to step up and do it. So